Chapter 24. Okay, nursing care for patients with occlusive cardiovascular disorders. You can find this chapter starting on page 401. Our learning outcomes are outlaid here for you. Go ahead and make sure you review those. I told you all that you had a lot of key terms to go through for these 6 chapters. Leading causes of disability of death in the United States, cardiovascular disease. We talked about this a lot. I hope if nothing else you do get from me that this is the #1 killer in the United States. You hear my voice in the back of your head when you're asked that question. Affects quality of life and activities of daily living. Absolutely, right? We see extreme weakness. We see decreased cardiac output, which affects the person's ability to maintain regular lifestyle activities. Modifiable factors lead to cardiovascular disease. What are modifiable factors? You know, smoking, drugs, alcohol, lifestyle, lack of exercise. What are things that are not modifiable or unmodifiable would be like our sex, where genetics that we are passed down. So we want to focus on what modifiable, what can we change, right? Education is vitally important to prevent and treat cardiovascular disease. Okay, so here's just some statistics for you. Men are a little bit higher prevalence, but women are definitely included in cardiovascular disease equally. So, or not quite equally. Like I said, they are slightly below. Men have are at higher risk for, and those over 65 definitely. Why? Because our main issue that happens is thickening of the arteries, arteriosclerosis. So that loses elasticity, like most other things in our body as we age, calcify. So you just have to be conscious and work harder with maintaining what you can. Atherosclerosis is a type of arteriosclerosis. These are plaque formations in the arteries. So they can begin in childhood and progress in coronary artery disease. Okay, so we will look at that as well. Patho is injury, inflammation to arteries, endothelial cell lining. Smooth muscle cells grow despite damage. Collagen and fibrous proteins are secreted. Lipids, platelets, clotting factors accumulate, and scar tissue replaces some of the arterial wall in atherosclerosis. Okay, so we can see an early or fatty streak, plaque buildup. It causes irregular, jagged shapes. So again, we can see this in that diagram. Figure 24.1 is of the diagram above. It's on 402. It's a normal artery on the top and then atherosclerotic artery on the bottom. So you can see how the abnormal edges would prohibit blood flow. Patho for atherosclerosis continuing is, you can get blood clots here. They break loose. They cause, you can have a heart attack, DVTs, all different types of complications, right? We talked about what non-modifiable risks are and what modifiable risks are. So please make sure to read up and be knowledgeable on all of those, because that's 90% of what we do, right? Patient teaching, at least. So very important for you to know, no matter where you're working and what type of environment. Diagnostic tests. Cholesterol, so fat in our blood, right? And what kind? Low density, LDL, and HDL, high density. You want to have high HDLs. These are the healthy, healthy. Low is bad, think of. So LDLs you want low numbers, and the HDLs you want to be higher. And so you want to have cholesterol checks done regularly. at age 65 or over, or unless you have predisposition with genetics, you're genetically predisposed to get our atherosclerosis or any kind of cardiovascular disease. These are continuing on workups that we would do on lab. We can make sure that we definitely are eating in a heart healthy diet. What does that mean? Obviously, the more healthier, unprocessed, non-fast food, non-fried, more whole grains, more plant-based diet. There's a lot of information out there. I've given you some, so lots and lots of information about all this, but it's definitely proven that at least eating high vegetable, grain diet is going to be a heart healthy. So you want to keep the cholesterol count down, any kind of fatty foods. So like fishes, white meats, if you're going to eat meat, and then no smoking ever, regular exercise, walking at minimum, swimming, any kind of physical activity, and then taking lipid-lowering agents as needed. Coronary artery disease is obstruction of coronary artery blood flow. So it usually is happening from the atherosclerosis. So because as the illustration illustrates on 24-1, why the blood flow would be cut down is because, it's clogged, right? The pathway is clogged there. So that makes sense. It can cause angina, an MI, or death. Prevention, we want to have the same things here. You got to low dose aspirin to keep your blood thin, in addition to all the other things that we've already covered with atherosclerosis. Instead of angina, you can have chest pain. It can be from coronary artery disease, vasospasm, valvular heart disease, hypertension, or heart failure. Angina is narrowing of the blood vessels so they're unable to dilate, so it causes that pressure and pain in the chest. Carrying less blood flow for the heart muscle, less oxygen causes MI, myocardial ischemic, and it is painful, so it can radiate into the arm, extremity, and you just overall, generally people will say they feel very tired, they don't feel right. Types of angina, you can have stable angina, and this is a moderate exertion in familiar pattern, so people might notice that they're getting tired with just getting around their house and to do things that they normally have done. They have to have stops. They should carry nitroglycerin with them. I worked for a cardiologist, and I had patients that I would schedule their appointments, and I worked in the front desk, and they would always show me that they had their nitro, like the doctor had ordered for them. They would carry it, some in a little necklace around their neck. They would have a vial in their pocket, like it was carrying their wallet. So it's just something that they always have with them. They're small little tablets, and you can put one under your tongue. It's going to be a very sudden rush of opening of blood vessels to get blood flow. So it's meant to be a fast acting. Pain is predictable. Unstable angina is when it's unpredictable. So they're not knowing, it just hits them all of a sudden. This is with less exertion. So, and it can even be at rest. They can be sitting in a chair. They can be sitting at their desk. It can happen in their sleep. It is unrelieved with rest, so it doesn't help. This is usually more severe. They can have blood clots that are reducing the blood flow is generally what it comes from, and it will lead to a heart attack, a myocardial infarction. Variant angina, this can be from a heart arterial spasm. They usually have a longer duration. It can happen also at rest. At the same time each day, generally at night when they're a little bit more quiet, and so they are noticing maybe more things about their body, that's what's going on in their body, and it is very serious. Microvascular angina, spasms in the walls of the tiniest arteries of the heart. Pain is more severe and lasts longer. All angina, right, can be serious. It's cardiac related, so those are always on the more serious. Heaviness, tightness. So people will say that they feel like someone is sitting or pushing on their chest. It can be a crushing pain. It may radiate into the arms, the shoulder, their neck, their jaw, or in their face, and or into their back. It can be closely mimicking of anxiety, panic attack symptoms and pain feelings. So you want to make sure that you're looking at, because that can happen in people over 65 as well. So, and young people can also have cardiovascular disease or heart attack or some type of thing that they're going to get angina. So, either way, they would probably, have to have that checked out. But if they have these, are the symptoms that generally we see with angina: pain, diaphoretic, they're profusely sweating, they have their color definitely changes. In women, they can have this chest pain, jaw pain, heartburn, atypical symptoms, so it's less severe pain. Fatigue, nausea, and breathlessness is not as common. These are the various tests that will be done. We've reviewed a lot of these. Goals for angina, we want to find out what are the risk factors. Weight reduction, so what are the modifiable things? These are the things that we can modify right here. Weight, diet, stress levels, right? You want to give, as ordered per doctor, vasodilators. So they have nitro patches, they have sublingual nitro, they have IV. We have calcium channel blockers such as Norvasc, Cardizem, Delacor that you might have heard about, or amlodipine, dilazetam. So you guys have given these, I know. Beta blockers, propanol, metoprolol, and atenolol. These are what do you see in common here? The LOLs, right? So OLOs. So make sure that you remember your farm and that prefix, suffix sheet that I gave you like forever ago. You can find it on Pinterest. You can find it anywhere. There's lots of, so you see here your pearls, right? These are angio and converting enzyme inhibitors. You need to know these. This is calling back now this information, and you need to put it into action. So your statins, these are for cholesterol lowering agents. So you need to make sure you know the different statins right here. And antiplatelets, so aspirin, Plavix. Nursing diagnosis. Okay. Coronary artery disease and angina, acute pain. So IV access for drug administration. We want to help them to rate their pain, find out what severe pain, if they're having severe pain. Oxygen, nitro as ordered. If it's not relieved in 3 doses, generally the order is you don't give more than 3 doses, or they should not take more than 3 doses without getting it's not helping then. It might be too advanced. Administer aspirin as prescribed. You will see like they have to chew up an aspirin. Sometimes if they don't have nitro, if someone's having chest pain, you can have them do this. Administer morphine as prescribed. Remain with the patient. We never leave these patients unsupervised. And provide emotional support. Knowledge deficit. Okay. There's lots of patient teaching here. Acute coronary syndrome. This is unstable angina. Includes MI. Okay, this is ST segment changes, elevations. MI without chest pain, so silent ischemia. This generally happens in older patients, and it is seen with hypertension and diabetes. So obviously very dangerous because sudden cardiac death. This is triggered by a lethal ventricular arrhythmia. They don't have warning. It is often just sudden and can happen in their sleep. They need immediate prompt treatment if they're going to have a chance at continuing with life. A myocardial infarction is death of the heart muscle. So just like it's saying, it's like stops the heart, the muscle. The patho is coronary artery blockage, which reduces blood supply and will finally cut off, is the end stage. So what different types? Non-STEMI or partial blockage, or STEMI is a complete blockage. Okay, myocardial infarction continued. Here is a diagram for you to see. Those are common areas of ischemia, of necrosis. Make sure that you read all of these. There's a good illustration of the locations of anginal pain on page 407 in figure 24.2, and it talks about nitro in the Be Safe box on 406. So lots to review here. We're on page 411 with these diagrams or illustrations. These are just showing you again where your we did in the previous chapter cover blood flow, right? So you can see here where damage and right coronary artery, okay, where that damage has happened. MI signs: crushing vice-like pain radiates into your arm, shoulder, jaw, and neck. Profuse sweating, dizziness, fainting, dyspnea, nausea, and restlessness. Everyone handles pain differently, so heart failure, extra heart sounds. You can hear wheezing or crackles often, and if you auscultate their lungs, their chest, they might timely treatment of MI, denial, calm, and wait to see. It's very overwhelmingly terrifying. So people handle this differently, but you have really little to in no time. You need to act in very stat. This is the highest priority. 911, all the alarms going and everything. So CAD, MI leading cause of death in women. African American women are at higher risk, higher mortality rates than men for women. So women are less likely to recover from an MI, more complications than men. And so men have a little bit higher risk of getting it, but we have a little bit longer or more severe mortality rate. Women delay seeking treatment. They may have atypical symptoms and are given less aggressive treatments than men. Absence of classic pain, dyspnea, fatigue, anxiety, chest cramping, restlessness, falling, all of these are the atypical signs and symptoms. Older adults and MIs, we can see these here. You can have a silent MI, as I stated before. Coronary, consider patient history. So, again, lifestyle, a lot of things that we've covered in the last 3 chapters here are going to continue. You want to make sure you do serum blood tests, that you're looking at troponin levels, making sure that they're coming in as the doctor ordered them, getting them to them when they are abnormalities. This is a ST. This EKGs changes with a STEMI, so you can see the ST elevation here. So do you see it here? And then there's ST elevation, right? See the Q wave differences? So again, you can see these on page 413. You can study them a little bit more in depthly. On figure 24.5, it will outline for you the various Looking at the learning tip here, Butler learning tip box, table 24.6. Just review these tables, gerontological issues with age and the ability. So just talking about when pain is not present, that's why MIs can be fatal and are dangerous, because they often, you don't have any idea. Pre-hospital care. It needs to be uncoated adult aspirin. That will help if you are if they're having and you're on the way, or you don't have anything else and you're trying to call 911. You can get an aspirin into the person's mouth to have them chew it up, but it has to be uncoated. Here are the different therapeutic interventions, invasive procedures. So they'll take them, if they have the ability to get them into the surgery room, do an angioplasty, put in coronary stents. This is a really very good illustration of, here's the plaque buildup right here, right? It makes sense. Why is the blood flow decreased? Because all this buildup. So they put in a balloon. An angioplasty will insert that catheter, and then they will expand it. So that as it's expanded, you see how they have opened up the airways like a rotor-rooter. That's what the cardiologist I used to work for called it, a rotor-rooter. So you go in there and you just open it up, and then now we have a little bit more of an open freeway there for blood flow. This is a stent, so they actually leave these in place. So depending on the cardiologist doing the procedure, they determine whether it's going to be a balloon angioplasty, or do they have to put a coronary artery stent in. They might have both. It just depends of a lot of different factors. But this is like a mesh, actual foreign object that is put in place and left there. So you can see here the catheter inserts it, then they expand it with the balloon, then they deflate the balloon and withdraw it with the catheter. And it left in place here is now this nice little framework that pushes the buildup aside, and they can have, this person can experience blood flow as it should be more open. So you can read about that and see those on page 414. Bed rest, bedside commode, they have very little energy and should not be pushed. An intra-aortic balloon pump, glucose control, daily weights, low sodium, clear liquids, low fats, low cholesterol, low sodium. They say low flavor. They always joke about that. So no caffeine, no stimulants like that, right? Weight loss, no smoking, antiplatelets, statins, ACE inhibitors, beta blockers. Often these people were living a lifestyle, working, smoking, drinking, doing whatever, and then they have a heart attack, and the very next day they are happy that they are alive, but they have to change their life instantly. So it is very overwhelming and very daunting. And so as much patient teaching and support, non-judgmentally, that you can offer is great, and it's necessary. Myocardial Revascularization. So this is coronary artery bypass graft. This is a different procedure. This is going to coronary artery occlusion bypassed with veins and arteries. So they'll actually do a bypass. And we'll show that it increases the blood flow and oxygen to the myocardium. So here you can see they take the vein, the artery, see this saphenous vein? They'll take this from their leg and they use it up into their heart right here. So it's all these people, this is on page 417. These physicians that develop these it's really incredible, right? This is, if you think about how did they come up with this. we're going to take a vein out of your leg. This is right by the femur, your thigh. And they're going to bypass. So here's the blockage, and they're bypassing it. They're just going to go right around. So they attach here, the vein, and then on the other side, and they will get blood flow happening to the rest of the heart as needed. These are the different types of bypass surgery that can be done. This is, you're working with a cardiologist specialist. I did work for a cardiologist. So you, in fact, may find yourself working for a cardiologist. You never know. But it's good to be familiarized with your own cardiologist, wherever you're working. And there's a lot of specialty stuff here. But in terms of our exam here and what you need to know for your NCLEX, this is what we are going to cover. Here's nursing diagnosis options. Nursing care, monitor their vital signs. Absolutely, that is our job. Monitoring for arrhythmias. They're always beyond telemetry. Report any symptoms. Providing incisional care after their surgery. They're going to generally crack their chest unless they are able to do a Da Vinci robotic surgery that will be a smaller incision. Some can be done that way now. And monitor them for depression. As I said, it's very overwhelming, and think about, them, they're thinking like they could die, which of course they can, because this is like they are working with their heart, and there are lots of risks for possible infection and other complications. Patient education, disease information, talking to them about their disease, cardiovascular disease, medications. They need to know all about their medications. They're going to be on probably a laundry list. They're going to have a lot of medications that interact with other things. Even when they go to the dentist, right? They cannot just go to the dentist to get their teeth cleaned, and they have to go every 3 months to get it done. They have to take antibiotics prophylactically. So this is a very encompassing, affecting disease. So patient teaching is vast here. They need to be activity, exercise minded in where they're at. So they might start just, only being able to do a little bit, and then as they are recovering, it can increase. Going to rehab and participating in a full program generally is a higher rate of success for a person, which makes sense, right? Because it's a lifestyle change, and only other people that are going through that are going to understand that. Reducing your stress levels, no job being worth your life. So you're helping with your family. Then the people that are alone that have to go through this. So rehab programs are excellent. Here we are, cardiac rehab begins in the hospital. They have outpatient programs as well, which are highly recommended for success, continued success. Common in older adults, and this is peripheral vascular disease. You'll see PVD often. So types arterial and venous are the types that you'll see. Arterial thrombosis and embolism. Artery blood clot can become embolus. Patho, it's arterial occlusions. Sudden and dramatic. They are common in lower and upper extremities, generally in the legs. The lower legs is where the extremities where they can't walk. Their legs hurt. They can't, it's just, they're heavy. They're painful. They just are very unsteady on their feet. Thrombus, it will break off so they can have an embolism that's going to travel, can kill them. It's very severe, cause a heart attack, any of those things. Signs and symptoms may be abrupt onset and acute arterial occlusions, chronic arterial insufficiencies. Symptoms may develop more slowly if collateral circulation is present. Symptoms depend on artery occluded and tissue supplied by artery. Gangrene may develop rapidly. Okay. These are the 6 P's: pain, pallor, pulselessness, paresthesia, paralysis, and poikilothymia. Okay. You can read about these in your book. Definitely peripheral artery disease is on 423. And as we continue, Berger's disease, you need to read about Berger's disease. Raynaud's disease. What is Raynaud's disease? It is they call it a phenomenon or a syndrome. Blood vessels it's usually in their hands and their fingers, and they get it could be from stress, but they often turn blue. They're very cold all the time. It's seen generally with rheumatoid arthritis, scleroderma, lupus, and endocrine disorders. So it looks like their hands just get like a bluish. It's very obvious, and blood flow returns to normal in about 15 minutes. So it's just kind of something that can come on. Some women have it longer than others. Okay. Peripheral artery disease. We're continuing on here. Chronic disorders. I'm trying to keep up with where you're at in your book. Here's Raynaud's. Okay. Compensatory mechanisms: peripheral vasodilation, anaerobic metabolism. So this is in the areas of people that are having this peripheral vascular disease. When it becomes extensive, they can get gangrene because they're basically no circulation in their lower legs or their arms. And so this is because, right, blood flow has to pump from your head to your toes nonstop, right? And so people that have this compromised and have peripheral artery disease, and they have a lack of blood supply going to these areas, so they will get breakdown in their extremities, mostly in their legs, their feet, and so they often have to have amputations. Signs and symptoms: it occurs late in the course of disease, generally when they are made aware with signs and symptoms. Women may have no symptoms at all. You can have pain in the extremities, can be really all constant pain. Muscle cramping, which is very painful. Hair loss in the lower calf and ankle, dry, flaky, scaly skin, thickened toenails. Again, this is all from decreased blood flow, right? So which causes low circulation, and we see all these things as a result. Intermittent claudication, cool skin, reddish purplish when dependent. You've seen people with peripheral artery disease all the time. You see this. You don't maybe always know, but when you see these signs and symptoms, you see those red purplish blotches in their calves and their in the front of the legs, and they have very diminished, absent pedal pulses. This is why. Ankle brachial index, so you can check for their pulses here. You can do Doppler, MRI, CTs. These are all things that will help with that, to check those. Yes, low fat, low cholesterol. So diets, what are modifiable things that we can change? Therapeutic. Okay, this is a procedure that they will do, and it's very similar to the ones that we talked about. So here is another bypass procedure, and this is outlined for you on page 431. Aorta femoral bypass. So again, it's very invasive, and there's a lot of patient teaching and a lot of risk for infection here. Ineffective tissue perfusion. Yes, these are your nursing diagnosis options. Okay, here's Raynaud's. Sorry, I jumped the gun sometimes. It generally affects women in older and colder climates. It's usually in the fingers, hands and fingers, and blanching, painful, and reddening. So it turns like a reddish, more bluish, like that looks like they have a tourniquet on or something, or like you don't understand why. And if you touch it, it turns white, like so it's blanching, but it goes back to that reddening. And so what you can do for them, help them keep warm. A lot of women with that experiences carry gloves with them, so they will put gloves on. Avoid vasoconstriction, and they take vasodilators to keep blood flow open and flowing as much as possible. Nursing care, patient teaching, protect their hands, wear gloves in cold climates, and again, it can be triggered by emotional stress. Buerger's disease, I told you that you do need to review Buerger's disease. It's a reoccurring inflammation and thrombosis of the small and medium arteries and veins of the hands and feet. We don't know. It's part of the autoimmune family, they believe, often associated with that, similar to, scleroderma. I can't think of it now. I just said it a little while ago and I can't think of it. The ones that, they're autoimmune disorders that a lot of fatigue, myalgia, fibromyalgia. Thank you. Fibromyalgia. Okay. Those are associated generally with Buerger's disease. In that family, autoimmune. Use of tobacco must be avoided in everything. Don't, always you want to teach anyone with these. Intermittent claudication, vein inflammation, numbness, and pale digits with a cold exposure, similar to Raynaud's. Distal extremity ischemia, so they can have ulcerations, which can lead and to amputation. Okay, so there's no cure for Buerger's. It's like autoimmune. That's why it's so similar to autoimmune, kind of put with them. Therapeutic interventions, immediate tobacco cessation, vasodilators, educate them, help them, support group. Aneurysms. Aneurysms are on page 427, figure 24.9, and we can see you are all familiar with an aneurysm is. You see how, there'll be a diagram that you see 24.9, the different types of aneurysms that there are. A triple A, that's a abdominal aortic aneurysm, can be deadly. Any of these can be actually. These are the different kinds. When they tear away from the wall, you're looking at death. Very severe immediate action is needed. Symptoms may be vague. They might have just a back or flank pain. There's a pulsating abdominal mass. So generally in the middle of their stomach, in their abdomen, there will be like a pulsating, like an awful, like, looks like an alien. And then it can rupture. So that is an onset of like severe pain. Then that's like they're not able to talk. They can't walk anymore. Like it's, and they'll go into shock. This is an immediate situation. These are tests. We want to control hypertension, prevent any ruptures, of course, bypass graft if it's possible. So they'll need surgery, absolutely 100% immediate surgery. Patient education, these are all the things that we want to do for that. Varicose veins. Okay. Varicose vein, you might all be familiar with varicose veins. We see them very often. You don't have, some people are genetically predisposed to these as well. They are like, they look like ropes sometimes in people's legs generally. It can be primary, secondary, structural defect in the vessel wall. So dilation of the vessel leads to incompetent venous valves, and so the valves are affected and they propel the blood forward, which causes them to be deformed basically. Secondary, congenital or acquired patho of deep venous system. So again, this is what this is talking about. It just basically causes a malformation or deformation of the vein. It's definitely from attributed to prolonged standing, a lot of weight. So during pregnancy, or just if you have long-term obesity patients, that they're carrying so much weight, it's hard on their bodies. So they can, their blood vessels or veins can be broken down and they get deformed. Telangiectasias are spider veins. These are the ones that we more often see in our thighs. It can cause a dull pain or cramping. We have swelling, edema, heavy feeling, ulcerations, and disfigurement of the lower extremities. These will be in conjunction with varicose veins, the spider veins. You want to reduce contributing factors, relieve pain, elevation, put your feet up, exercising. Compression stockings are useful or helpful with this. They will have, and you can do injection or sclerotherapy. They put saline generally, and it can help break that down. Radiofrequency ablation, laser, or vein stripping, which does not sound pleasant to me, but a lot of people get this. Vein stripping, but it can be very helpful if you have severe, that's leading to blood flow problems. Chronic condition and damaged aging valves causing pooling and the blood and lower extremities, and venous insufficiency is what we're talking about. Chronic venous insufficiency may lead to venous stasis ulcers. This is from chronic venous insufficiency. There's a rupture that causes leaking of red blood cells into the tissue. So it's like a bruise, broken, blood vessels, and they just leak out into the tissue. So it will show like a bruise, kind of. It's a brownish discoloration, and it can be hard, leathering skin. You've seen this a lot in people in the hospital, everywhere, Parker and JFK. They are usually people that are heavy, and not always, but generally, and they have that very hardest, shiny kind of skin in their lower legs, and it looks very hard and leathery. That's a very good description. And it is swollen often, lots of edema. Develops at the ankle. These are stasis ulcers. So they are difficult to treat. It can affect their quality of life. You want to decrease the edema as much as possible. There's lots of things you can do, like compression wraps, bed rest, have their feet up, their legs up. They should not be on their feet a long time. They should be walking in small, they need to be ambulating, but in small increments. So with rest, and then they have to put their legs up, and then Una boots are good. Skin grafts can be done for the ulcers. Here is some nursing diagnosis. Wound care. These are high risk for infection, right? Emotional support, education, all these things. Don't cross their legs. They cannot be crossing the legs. No tight clothing. avoid heating devices, apply compression from foot upward. So that's why the Ted hose kind of stockings are recommended. They can be, this is an embolectomy and thrombectomy. It's a surgical emergency. Restores blood flow and oxygen. Vascular bypass and grafts. Excuse me. Endarterectomy. Angioplasty. They're just different types of procedures that can be done. Stents, we talked about those. I showed you a diagram of those. Our therapeutic interventions. Yep, monitoring. So we're monitoring not just vital signs, labs, INOs, their incision sites, because they are definitely at risk for infection. We're doing neuro checks. We're doing, there's lots of nursing care here. Lymphangitis, this inflammation or infection of the lymphatic channels, which can be serious as well. It can occur in your arms and legs. Serious infection may cause sepsis, pain, red streaks, chills, and fever. Antibiotics. Monitor for edema and skin breakdown. Okay, we finally made it to our review questions. So make sure that you do review questions.